Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Sachin Allahabadi from Houston, Texas. Dr. Allahabadi is an orthopedic surgeon at the Houston Methodist, the Woodlands Hospital, and also associated as assistant professor at the Weill Cornell Medical College in New York. After completing his medical school at the Baylor College of Medicine with highest honor and induction into the Gold Humanism Honor Society and Alpha Omega Alpha Honor Society, Dr. Allahabadi completed his orthopedic surgery residency at the UCSF in San Francisco, where he was awarded the Chief Resident of the Year. He then completed his fellowship in sports medicine and shoulder surgery at the Midwest Orthopedics in Rush University in Chicago, where he received the Fellow Research Award. Dr. Allahabadi has several high-impact publications in top-notch medical and orthopedic journals. So today is my great honor to introduce you to Dr. Sachin Allahabadi from Houston. Over to you, Sachin.
Thank you so much for having me. I'm really excited to be a part of this program. You have yourself a lot of credit for creating such a wonderful program and educational system through Orthopedic Principles, and I'm just lucky to be on here. So today we'll be talking about articular cartilage injuries of the knee. I'm going through sort of a framework and approach how to address and look at these. I have no disclosures, and before I really begin with the talk, I really have to owe a lot of credit to my mentors at Rush, especially Brian Cole, Dr. Yankee, and Dr. Chawla. Each of these people have dedicated their careers to different aspects of knee joint preservation, and I've learned a lot from them. I'm lucky to have trained at Methodist Orthopedics at Rush, where we have one of the highest cartilage restoration volume centers in the world. And so I really owe a lot to these guys. So, the first question we always ask, like, why do we care so much about articular cartilage defects? Well, number one, patients who have them, they have a very poor healing potential. The articular cartilage has limited blood flow. There's limited potential for chondrocyte adhesion migration. And the cell density, especially in the articular surface, is much lower. In addition, there's a dense extracellular matrix structure, which can make it challenging to heal. And articular cartilage, especially in the knee, is under frequent loads in different planes. And so it makes it very challenging for it to heal with the mechanical stresses that it's under. The other thing is that articular cartilage defects are extremely common. There have been numerous studies looking at thousands and thousands of knee arthroscopies, and the results of these demonstrate that an articular cartilage defect is found in at least 60% of knee arthroscopies, which I would say is certainly the case in my practice as well. And they're especially common in athletes. We know that through other data, competitive athletes have a higher risk of having higher grade defects and a higher risk of having more defects. Looking at professional basketball players, there have been studies that show that around 48% of basketball players have cartilage defects, especially in the patellofemoral joint. And notably in the US, a recent basketball player in the NBA, Lonzo Ball, has been publicly announced to have had surgical treatment for his cartilage defect. I was lucky recently to participate in a study where we looked at players in the National Basketball Association or the NBA Draft Combine and obtained MRIs on players as they were in the combine. And we found that 48.3% of patients in this cohort had articular cartilage defects to some degree. And despite this, however, there's very little correlation between what we see on the MRI and their reports of pain, function, or even injury history. So the main takeaway from this is even at athletes in the highest level, we have to be cautious about treating pathology that we see on imaging that does not necessarily cause symptoms. It's very common to see small articular cartilage defects in a number of locations on an MRI, but if that's not causing symptoms, then we should not be jumping to treat it. Well, another reason, people always ask, like, well, is this going to get bigger? Is it going to progress over time? Will these articular cartilage defects contribute to osteoarthritis? It is true that some defects do progress to bigger sizes. They may become symptomatic, and new defects may also form. And there's studies that show in patients who are awaiting autologous chondrocyte implantation after the first stage biopsy that sometimes their defects do get bigger or more expansive. However, these may not always cause symptoms. If you look at the natural history of these defects, 79% of patients with untreated defects return to sports, and studies cartilage defects that were identified at the time of ACL reconstruction have not impacted clinical outcomes in the long term. So what we need to think about really when we're approaching cartilage defects is treating this currently symptomatic defect. And there's this concept of skillful neglect that Dr. Cole has really been excellent at teaching us. And it's okay to not treat. And skillful neglect is not, putting your hands over your head and ignoring the defect. It's having the right conversation with the patient. And rather, it's treating the symptoms and not the imaging, and ensuring that you understand the patient's goals of treatment. Sometimes the patient's goals and their understanding of the defect and what it's going to potentially cause may be different than what you think they think it is. And so it's really important to have a good conversation with them. And Dr. Cole has a great video on his website about skillful neglect and how it can be an effective form of treatment. Additionally, there's several overarching principles and considerations that we should always think about when approaching cartilage defects. And this is generally in orthopedics in general. We want to do the least amount of invasiveness, the least amount of risk to make the patient better. So if I can get the patient better with simple non-surgical things, and they can feel better and return to their activities, and that's the best option. Additionally, we have to consider recovery timelines with any treatment. There are some patients who may be symptomatic, may have a defect that has failed non-surgical treatment or initial arthroscopy, and may be a good candidate on paper for a bigger cartilage restoration procedure, but their lifestyle or their current life may not be able to accommodate the recovery timeline that's necessary. You always have to understand what is contributing to the defect, what was the cause of this defect, and what kind of loads is this defect going to be withstanding. Because if we do not address those loads or the forces in the defect, then the defect will be much higher likely, or the treatment on the defect will be higher likely to fail. There's a great infographic in the Arthroscopy Journal with one of my partners, Dr. McCullough, that was recently published. And it talks about these 3 critical factors that all contribute to cartilage injuries. So number 1 is alignment, the status of the meniscus, and ligamentous instability. And to really preserve the knee joint, we have to be thinking about all of these factors together, because without doing so, we are much higher likelihood of failure. Start off workup, in my office, everybody gets weight-bearing x-rays, and that's critical. The number of times I've had patients come in with non-weight-bearing x-ray and they get a weight-bearing x-ray, and the joint space completely collapses is innumerable. And it's really critical to actually get a flexion weight-bearing view. Most of the cartilage defects are in the back, and this is the same patient from before to after, and you can see a huge osteochondral lesion on the lateral femoral condyle. Everyone in my office for cartilage defect also gets alignment radiographs, and the patient on the far right of the screen is in significant valgus on each side. And should they have presented with a lateral femoral condyle defect, this would be under a lot more load than someone who would be in a varus alignment. And then most of these patients have an MRI either coming in or we obtain one, and CT scan depending on the scenario. A lot of factors to really consider about an individual patient. Number 1 is their age, but really with age also comes skeletal maturity. A patient with open physes who's younger may be treated very differently from a patient who's older with closed physes. Also have to consider their activity demands and what the patient's goals of treatments are. And then when you have symptoms, what are the symptoms and what is the degree? A patient who only has symptoms when they do high impact sports versus a patient who has symptoms with daily activities, walking, may be treated a little bit differently. And then we have to also think about factors of the defect. These images are from a 55-year-old male presented with my clinic with this large lesion, and you can see a loose body and suprapatellar pouch in the upper right. And this would be treated probably a little bit differently than a 13-year-old with open physes. And so the size of the defect is really critical, but not only the size, it's the relative ratio of the size. Is a subchondral bone involved, and how deep is the lesion? Where is the lesion? We know the femoral condyle is very common, but is in the patellofemoral joint? Are there bipolar lesions? And then is the lesion contained or uncontained? Because that can limit your options as well. And by containment, we mean that there's a bridge of bone or cartilage on each side. And, again, the size of the defect, we always are measuring the size, but the size can be very different in terms of a ratio in a young female versus a larger male. When we look at defect sizes, there have been studies showing that it's not just the size, but the defect size to the condylar ratio. The larger that ratio is, the greater chance of failure. And the same size defect might be very small in a male versus a female. And when we think about cartilage, we frequently use the word cartilage, but really the bone underneath is absolutely critical. And we need to be considering the whole osteochondral unit, because those lesions without an intact subchondral bone bed have much higher failure rate of just treating the surface of cartilage. So generally, one of the first decisions we're making is, should we treat this non-surgically or surgically? Usually acute onset symptoms of patients who still have maintained performance, we manage non-surgically. Incidental defects in MRI, symptoms that do not correlate, those are non-surgical. Certainly patients who have ongoing symptoms despite non-surgical treatment are more likely to have surgery. Those are mechanical symptoms, symptoms that are impairing their performance in their sport, or affecting their daily quality of life, are far more likely to consider surgical treatment. And the other thing to consider is that many patients will regress to the mean. And what that means is, we see patients in the office who have symptoms. And more often than not, the defect or the lesion that they've had has been present for longer than they've had symptoms. And sometimes we're just catching the patients in sort of one of these upswings. And with a little bit of patience, time, and non-surgical treatment, they will return to the mean and feel fine. So, this is another concept that's really important to consider is, how severe are their symptoms? Is this something that they can get better and return back to the mean and just they're in an acute flare? Or is this something that's going to continue to cause them issues? So the first thing, again, with non-surgical treatment is we don't have to do anything. You can skillfully neglect a lesion. We can give it more time. There's more and more research on injections and how we can mediate the inflammatory environment locally. And physical therapy can be really helpful. If someone has a lot of weakness around their knee or dynamic instability, you have them do a single leg squat in your office, and there's significant valgus collapse and poor control, they're more likely to benefit from physical therapy, and being able to correct some of those factors may reduce the forces that the defect is facing and therefore reduce symptoms. And the other thing to really consider is, how do we offload the defect mechanically? I use a lot of unloader braces in my office. Those who have higher BMI, we're always counseling them on weight reduction and the benefits of that. And sometimes they just need an acute period where they're not doing a lot of impact. So some of the things that I'm listening to a lot with the patients is, how long has this been going on? Is there or is there not swelling? And is this load dependent? I had a patient the other day tell me that they only had symptoms when they did box jumps, but never otherwise. Well, that sort of description is less likely to benefit or make me excited about doing surgery than someone who's having mechanical symptoms, pain with daily activities. And so ultimately, you have to ask the patient, what are your goals of treatment? Some patients say, oh, my goal is to, prevent OA, or my goal is to, be able to sprint, or whatever it is. Understanding what their goals are is really critical to be able to counsel them on what our rates of success might be and how we can get them better. And so those who are unable to get better with non-surgical treatment, there's a variety of surgical procedures that are described. And we'll kind of walk through a lot of these when I think about using them, and which ones we can use in different environments. And the caveats to any algorithm, whether it's the approach that I'm going to present here or any others online, is that they don't always make sense for your patient scenario. One of the fun things, but also challenging things about cartilage surgery is that it is not straightforward. And that's why we have these talks and these algorithms and debates on what to do and so many different treatment options, because it's not that straightforward. And so we need to take into account patient-specific factors, consider if the bone's involved or is it just the cartilage surface. And another key thing is, it's important to understand your personal skill set, your experience and exposure. Because if you're not as familiar with the treatment, it may not go as well in your hands, and it may be better to try a different treatment or even consider referrals. And then considering the cause of the defect. Again, why did this defect happen? Because if you don't address the cause, then the patient will have much higher likelihood of failure, more likely to continue to be symptomatic, or have worse outcomes. And lastly, everyone in the world has different resources and allocations available to them. So there's some regions in the world where allografts are not really that much of an option. So an osteochondral allograft, it shouldn't really be in your personal algorithm. So knowing your personal resources is critical. And ultimately, what I'm hoping to do today is not make this very complicated, like this image here, but really try to take everything and try to simplify it. So generally, for smaller defects, the solutions that we tend to think about are chondroplasty and debridement, marrow stimulation, some of these single-stage off-the-shelf solutions that are available, and osteochondral autograft transfer. And as we get into larger and larger defects, for me personally, I'm thinking a lot about chondroplasty still as a staging procedure, and the patient may do better, and subsequent autologous chondrocyte implantation or osteochondral allografts. A little sort of separate note is about OCDs and fragments. Many OCDs that are stable, especially those with open physes, will do better without any surgical treatment. The ones that we tend to treat are the unstable ones. So in the ROC classification, in the lower half of that, the mobile lesions are far more likely to need treatment. Those with open physes do better, which corresponds with younger age, and consider the time frame that the patient has had symptoms. If they've had symptoms only for a week, it may be much more reasonable to non-surgically observe it as opposed to symptoms for multiple months. And when we do fix these defects, there are different ways that we can do it. I personally prefer using metal screws. The disadvantage to using metal screws for fixation is it does require a second surgery for screw removal. To me, the advantage in that surgery is you get to see if the defect healed directly. Bioabsorbable screws are also a great option, which allows for a single surgery, but they may have some downsides, including prolonged time to absorb, and some patients have a reactive synovitis or effusion. But bioabsorbable screws, we did a study when I was in fellowship with Dr. Cole, looking at bioabsorbable screws for patients with stable lesions that did not improve with conservative treatment, and it shows pretty good results so far. Now, I would honestly say that the chondroplasty or debridement is like my workhorse approach. It's the first thing I do in almost every case. Almost every cartilage surgery for me gets a staging arthroscopy. And so that's where we look at the defect, and we usually clean up the edges. And what we do in the chondroplasty is we try to create a sort of beveled chondral defect at the edges, which helps reduce forces on the area. You're also getting rid of joint debris, which may cause swelling and pain. May improve mechanical symptoms. And the benefits is a simple, low-cost procedure. Most of these surgeries are done in less than 30 minutes, and the patient has very quick recovery. And a large proportion of patients do get better with just a chondroplasty alone because the edges of the defect, loose chondral flaps, are what are causing their symptoms. And so, I talk to all my patients and say, hey, there's a 50% chance that just cleaning up the edges of the defect may make you feel better, and it'll help us with staging and does not burn any bridges for subsequent surgeries. And when you're looking at this, these are studies that are looking at articular cartilage debridement, and you can see that patients do improve on average over time. And when you look at patients at even the highest level, in the NFL athletes, return to play after chondroplasty has been shown to be up to 67%, and that did not correlate with size, location, or the player position. So chondroplasty can actually be very beneficial. Another thing to know is that a defect size on MRI may not always correlate with the size that you see on arthroscopy. In fact, it's often much larger on arthroscopy. Here's an example. This is a case I did very recently. There's a very small lateral femoral condyle defect. The radiologist had measured at 6 millimeters. When I got into the knee, this is sort of what it looked like, and you can see these loose flaps. And after chondroplasty, you get a defect that's more like 10 to 20 with loose flap edges, 10 by 20, where loose flaps are. And so the next step of treatment for smaller lesions is microfracture and marrow stimulation. And the interesting thing about this is that most studies for new cartilage treatments still compare to microfracture and marrow stimulation as the gold standard. What the downside to this treatment is that it forms fiber cartilage, and that's not really great for withstanding mechanical demands in the knee long term. All the initial studies were very favorable in the first couple of years, but over time, the outcomes really deteriorate. And another thing to know is that, when you are thinking about doing microfracture marrow stimulation, it does very poorly in the patella. So I would really not consider this an option for the patella. The fiber cartilage does not do well with shear, and the patella itself has very poor marrow access. And when you do a microfracture, if you have a lot of subchondral plate disruption, you may lead to something called osseous overgrowth. And you can see here in the lower right of the MRI, you have this intralesional ossified and overgrowth, and that can contribute to worse outcomes as well. If you are doing microfracture, I would certainly try to make sure the defect is smaller. We do know that subsequent surgery, a number of studies has higher failure rates after microfracture, especially with autologous chondrocyte implantation. So I'm very cautious with performing marrow stimulation for larger lesions, just to not impact our subsequent options. And when you're doing microfracture, if you are going to do it, it is certainly preferred to drill. When you drill, you have less subchondral bone damage, better access to marrow stroma. As you can see here on the left, that's a traditional microfracture all versus drilling, where you get much better access to the deeper marrow on this. If you have the resources available, doing what we call microfracture plus can be helpful. So this is one of these examples is micronized extracellular matrix. One of the more popular trade options is biocartilage from Arthrex. It's a single stage, and what they've done is they take a micronized dehydrated allograft matrix with ECM, and you put that over the microfracture defect. For me personally, I use this in small joints, and one of the benefits is that it can also be mixed with your own patient's own cartilage. So here's a capitellar OCD I was taking care of, performing a chondroplasty, and we did a microfracture, and you lay a fibrin glue on top, and then the biocartilage ECM is mixed with, in this case, mixed with the patient's PRP and placed over the defect. Another sort of microfracture plus, we call it, is something called AMIC, or autologous matrix-induced chondrogenesis. And this is another single-stage procedure where you place a porous collagen membrane over the top, and it's thought that the marrow elements from the microfracture then get stabilized into this matrix and then enhance chondrogenesis. Again, in most studies, shown to be beneficial for small and medium defects in the short term. As we're going through each of these, I'm trying to get through more hyaline, more normal cartilage. And so cryopreserved cartilage, what they've done is this is an allograft, and they do freeze this allograft, which generally is not that great for chondrocytes, but they add some cryoprotectants to it to try to maintain some of them. And this is an off-the-shelf option that can be beneficial. The nice thing is it's also moldable, so you can fit different defects very easily. The downside is not as good for bipolar lesions, localization of the patellofemoral joint showing higher failure rates, but this does add more hyaline-like cartilage than microfracture. And then another thing that can be done with an allograft is not an option, is using autologous minced cartilage. Another single-stage solution where you use cartilage that's either loose and or from lesser weight-bearing areas of the knee, and you mince it, and then you apply it into the defect area. Again, long-term outcomes still limited in terms of durability, but can be an option that's affordable and where other resources are not available. And then particularly juvenile cartilage, this is sort of one of the higher quality like cartilages in terms of single stage off-the-shelf solutions. It is an allograft, but it's specifically from donors typically less than age 13. The most popularized version of this is de novo from Zimmer Biomet. And because of the young donor, you have a higher chondrocyte density, proliferability, and viability. The tissue is considered to be minimally manipulated, and we'll get sort of a higher hyaline-like type cartilage. And more recently, there's been more data and interest in an aragonate-based scaffold, such as the Smith-Nechi-Cargill implant. And what this is, it's a biphasic implant where you have a bone phase that is supposed to basically help the structure of the subchondral bone, in addition to a cartilage phase that helps perform and mediate chondrocyte migration and adhesion. It's off the shelf. It's improved outcomes for even larger defects. And if we can get this available around the world, it might be beneficial. A recent multicenter randomized control trial that was published looked at 251 patients And they were compared, the comparison group was chondroplasty and microfracture. And the group undergoing treatment with the aragonite-based scaffold had a greater improvement in KOOS scores and greater fill in MRI. And if you look at this, one of the cool things about this, if you look at the picture in F, they have an elongated defect, and they put this scaffold at the top and the bottom of the defect. And over time, it's thought that the defect can bridge with cartilage and chondrocyte migration, even across areas where the scaffold's placed. So this is a near thing that I'm really excited about and interested to see where this goes. Now, when you get into, in general, when the bone is more involved, osteochondral autograft transfer has been one of the best treatment options that we have. But the downside being that it's for smaller defects. And one of the challenges is that smaller defects are not always symptomatic. And so, although I would love to use this more often, it's not as common that we find a patient with a small defect that's symptomatic. And what you do is you take an osteochondral autograft plug, usually from the proximal trochlea, and you transfer it to the area where the defect is. The downsides are donor side morbidity. People get knee pain at the site. And with larger defects, you may require multiple plugs, which increases the donor site morbidity and also makes it harder to find an articular contour match, especially for a place like the patella or elsewhere in the trochlea. But here on the right, we're doing a dissection, just a small little arthrotomy to get the proximal lateral trochlea, and then harvesting the plug from there. The benefit of osteochondral autograft transfers or OATS, it has the best return to sports outcomes. It's the patient's own tissue. It's cost effective, and it honestly has one of the best long-term successes. There's a really nice meta-analysis study looking at all the different cartilage treatments, and you can see that OAT has the highest return to sports rates, and I would say with faster return to sports. Now, of course, these defects aren't exactly matched because a defect undergoing an osteochondral autograft is usually much smaller than that undergoing ACI or osteochondral allograft. But within this limitation, it does quite well. And then we get into the, what we consider cell-based therapies. And autologous chondrocyte implantation has undergone multiple generations and evolutions, from much more challenging surgical techniques and extensive techniques with periosteal covered and collagen covered implants to now the matrix-induced implant, or otherwise known as MACI. And this is a biodegradable collagen scaffold, and that's a pre-seeded membrane with the patient's own cells that are harvested at an initial staging arthroscopy. And this results in better cell distribution than the prior generations. The downside to it, it certainly requires resources and cost. It requires a staging arthroscopy where you harvest the cartilage from a lesser weight-bearing area. Usually I use the intercondylar notch, but with modern techniques, you can secure it with fibrin glue. I still use a couple of sutures, although it's not really necessary. And I like this, especially in the patellofemoral joint, for really irregular lesions or areas where I think it'd be hard to find a graft match. The other benefit is now there's more arthroscopic tools to be able to do this even less invasively. And then, osteochondral allografts are sort of my passion area of interest, largely inspired by Dr. Cole. And the benefit of an OCA is that it manages the subchondral bone. You have a matched donor with great surface contour. You don't have to worry about donor site morbidity. The size of the defect can be quite large. And it's very good for load-bearing areas in particular. And this is really the optimal option for revision cartilage surgery. So prior cartilage surgery that's failed, the OCA has fared the best. Earlier we mentioned that ACI does poorly after previous microfracture in most studies. On the other hand, osteochondral allograft can still do quite well. And there's a study shown here that they looked at 164 knees after prior cartilage surgery, the majority of which were marrow stimulation. And even with that, 82% graft survival at 10 years. This is a study that we did when I was in Dr. Cole, looking at his patients. And these are professional athletes, so people who face the highest demands in their knees. And in this study, 15 professional athletes, those who underwent an isolated osteochondral allograft had a very high 87.5% return to sport. Those who had other concomitant procedures at the same time, such as a meniscus transplant, or others had still a 73% return to sport. And that's not just recreational sport. This is sport at the highest level, around 1 to 1.2 years post-op. So it's still a very powerful procedure to get people back to very high-level activity. And we made a video that was presented at the ANA meeting in 2023 and won an award for the best pearl in cartilage restoration. And this has subsequently been published in the Arthroscopy Techniques Journal. Just pearls to maximize the biologic healing and success of osteochondral allografts. And although this slide and the next few slides will be focused on osteochondral allografts, some of these same principles can really readily be applied to any cartilage treatment. So one of the main things we want to do is reduce thermal necrosis. One of the ways we've done that is by submerging the graft during harvest. We want to limit antigenicity and immunogenic elements. The bone, subchondral bone, is one of the areas where we get more immunogenicity, and so we want to minimize the sort of depth of the subchondral bone. And then we do a number of things to prepare the graft to enhance incorporation that we'll go into. So another consideration that's really important with osteochondral allografts is matching the topography. And everyone looks at matching the cartilage surface, which is obviously certainly critical. But if we can match and find better ways to match the subchondral bone, it's better. And understanding where the defect is exactly on staging arthroscopy can be very beneficial. And we may not always have every graft and size available, but in some studies it shows that contralateral condyle may be also very beneficial. So as we're talking about immunogenic elements, a couple things that we do. So again, we minimize the subchondral bone depth. Usually we aim for a depth of around 4 to 6 millimeters of subchondral bone. We always pulse the graft with pulse lavage. That helps get rid of a lot of immunogenic elements. And then adding pressurized carbon dioxide can effectively clear marrow elements, especially in the deeper parts of the graft. And it also can prepare it to be better accepting of subsequent biologics such as bone marrow aspirate. The other thing that we need to think about with any cartilage transplant is the viability of the chondrocytes. We sort of alluded to this earlier when we were going through the single stage solutions, where the juvenile cartilage has a higher chondrocyte viability compared to, an extracellular matrix solution, which has no chondrocytes. And one of the couple of things that we consider with the chondrocyte viability is the impaction forces. We want to limit the amount that we're impacting on the graft. And this is the same for an osteochondral autograft or an allograft. We want to reduce the thermal energy. We did a study that was published in the American Journal of Sports Medicine, which is a part of my thesis fellowship, how the technique of reaming can significantly affect the chondrocyte viability. And so what you see here in this photo is we're reaming the graft submerged in a basin of water to limit thermal necrosis. And in our study, we showed that there's much better cell viability with the graft that's harvested in a submerged fashion compared to the traditional way with bulb irrigation. And then, bone marrow aspirate concentrate or other biologics may also improve the integration of grafts. A recent RCT published out of Rush demonstrated that those grafts pre-treated with bone marrow aspirate concentrate had a much smaller proportion of large cystic changes, and less likely to undergo subsequent surgeries. Again, we really cannot forget about the other factors, and people always consider these the other, but really, I wouldn't even consider them the other. I'd really consider them like just as part of health, the alignment, meniscus status, and ligament stability. This is a patient who had a large medial condyle defect, but he was also on exam and found him to have a chronic PCL insufficiency from a prior car accident. And so, in this case, he underwent a double bundle PCL reconstruction in addition to an osteochondral allograft of the medial condyle. And if we had just done the cartilage graft with this PCL insufficiency, there have been a lot of forces on that and failed. And there's been numerous studies over time demonstrating that more instability, chronic instability, more instability events, you will have a much higher rate of cartilage injuries and the severity of them. So I think most people understand that ligament stability is critical for cartilage. And the other thing that is absolutely critical is the meniscus. And meniscus preservation, if at all possible, should be the goal. And if it's not possible, then a meniscus transplant should be performed. And the meniscus has numerous functions. It plays a role in load transmission, force distribution. It's a shock absorber. It actually also contributes to stability of the joint and allows for lubrication and proprioception. And one of the benefits of the meniscus is that if you go back to physics, with force, pressure, and area, the meniscus increases the contact area and thereby decreases the pressure on the adjacent cartilage in the joint. And for patients who do need a meniscus transplant, most of the studies actually show that if you indicate the patient properly, their outcomes are largely similar to those who get an isolated osteochondral allograft transplant. And so it's really important to find the right patients, and if they need one, to address both. This is a matched group analysis by Dr. Frank, Dr. Cole, and others looking at the osteochondral allografts with and without meniscus transplant, showing very similar survivorship at long-term follow-up. And then the last thing is alignment and osteotomy. So osteotomies to offload the compartment certainly improve outcomes. I use a lot of unloader braces preoperatively to understand how the patient will respond to that. But those who undergo osteotomy to offload the joint have better PROs, lower reoperation, and ultimately there are even some studies that show that osteotomy alone can benefit cartilage lesions without cartilage treatment. We know this in the setting of arthritis in a single compartment as well, that osteotomy can help offload that. People can do quite well. So don't forget that osteotomies can be quite powerful. In the tibiofemoral compartment, typically for focal cartilage defects, patients needing a correction over 5 degrees is when I consider it. We have a video online on arthroscopy techniques describing tips and tricks for lateral opening wedge distal femoral osteotomy for a valgus knee, but certainly can be used in any fashion. I typically do opening wedge osteotomies, but it just depends on the deformity and where it is. And closing wedge osteotomies are also wonderful and can have even better rates of healing. And then there's even more, modern companies and things that will help you with custom planning of different osteotomies to make patient-specific guides. And so this is one of my cases that I'm planning here with the plate and wedge scene. And the patellofemoral compartment should not be forgotten. The patellofemoral compartment, an osteotomy can be extremely powerful. Those with associated patellar instability, especially those with an elevated tibial-tubercle trochlear groove distance, can benefit from an anterior medialization procedure. If we're thinking about cartilage, especially for panpatellar lesions or pantrochlear lesions, anteriorizing the osteotomy, the tibial-tubercle osteotomy, can be add additional benefit. And so you may want to consider steeper osteotomy cut angles as shown on the right. So for example, I recently just did a 60-degree anteriorization or 60-degree anterior medialization, which provides me more anteriorization compared to a traditional 45-degree. These slides are, I think, good to exemplify it. I got these slides from my mentor, Jorge Chala. So for inferior and lateral defects, the patella is riding on the lateral side, and where most patients can benefit from an anterior medialization procedure if the tibial-tubercle trochlear groove distance is over 15. If it's a lot smaller than that, then sometimes just an open lateral retinacular release or lengthening can be helpful. But for defects that are more medial or more proximal or diffuse, it can also be helpful to, again, anteriorize them more. And so you have a more vertical slope of the osteotomy. It can bring the patella more anterior, and this can be beneficial for the cartilage. And there's lots of areas of ongoing research, and I think the coolest thing about cartilage is that it's still growing. And people are looking more and more at synovial fluid markers, influence of local fat pads and bursae, and how orthobiologics can impact these things. So it's an exciting growing field. And I think, for the next few minutes is going to show a couple cases and describe some of the techniques that we have available to us. And so here's a case of a mid-30s male who had a large osteochondral defect of the lateral condyle and presented to me. So what we're doing here is we're going to start with chondroplasty right when I see the defect. You can see loose edges of cartilage. And I'm starting with a shaver just to define the edges of the defect and try to understand, where the stable edge would be. So you can see there's loose cartilage around there. And so we're going to work on this defect. I'll skip ahead a little bit. And I like using curettes on this to really define and sharply define the edges. This is a ring curette that I'm using to help, again, clear out the loose chondral flaps and create, ideally, a small bevel at the edges of the defect. And so, this can be a very powerful tool. Also, sometimes we'll use I'll skip ahead a little bit, use a standard curette as well, just depending on the angle. So we're cleaning this up. And then you can see you can really get a much better understanding of where the defect really is and how big it is and what you'll need to do to treat it. And then I always switch portals and view it from the other side, just so I make sure I understand it. And here I'm looking at the meniscus, and where the meniscus is critical. Thankfully, his meniscus was okay. And we found his loose body in the posterior compartment, which was removed through a posterior medial approach here. So, in this case, I did take a Mason biopsy, although, certainly my plan for this, when he was symptomatic, was to proceed with an osteochondral allograft, given the size and depth of the lesion. And here is, eventually this patient was symptomatic. We did take him back to the operating room. You can see a large osteochondral defect in the lateral femoral condyle. His alignment was normal, his meniscus was normal, thankfully for him. And, in most cases, I do 2 overlapping plugs. In this particular case, we did do an oblong plug. Just seemed to work well for him. And so this is us preparing the defect bed. And then this is after implantation of the osteochondral allograft. Here. This is a case of an OCD lesion. This is a mid-30s triathlete who was symptomatic, unable to do his activities. As you can see from his alignment radiographs, he was in varus alignment. And so he was seen, sent to me as a second opinion, came to me as a second opinion. Another surgeon had offered him a loose body removal and then osteochondral allograft. But we looked at it, his imaging, that was reasonable to try to fix. And if he fails fixation of the defect, then we would plan for an opening wedge high tibial osteotomy with an osteochondral allograft at the same time. He also had a meniscus tear on the MRI that looked to be sort of horizontal in configuration. And so when we get in here arthroscopically, this is his meniscus. There's some frayed edges. Looks fairly degenerative. So we're going to clean this up here. And you can see there's a horizontal tear in the back. And given that he's already in varus, we're trying to preserve his cartilage. We thought that meniscal repair would be beneficial in this case. So I'm preparing the edge of the tear. And then I'm going to pass multiple, let's see, place the cannula and pass multiple horizontal cleavage tear reduction, like hay bale sutures around the tear. And these are all tied arthroscopically. And remember, the meniscus is, any meniscus that we can save will be beneficial. And also in this case, I know that I'm coming back here, like I mentioned earlier, I'm using metal screws for most of my fixation. And so I know I'm going to have a second look. And so if I can try to get this meniscus to heal, and if it doesn't heal on second look, then I can always do a partial meniscectomy if necessary, or revision repair. But this is what we did here. So I'm tying multiple sutures, and we're going to pass a bunch around here. And we're looking at it. Here's the last one going in. And then here's the edges of repair. So there's 4 stitches in here, which is important. We'll look at that in a second. And then here's his osteochondral defect, or his OCD lesion. Okay, so you can see I'm touching it, and it's extremely mobile. I'm just touching with the shaver, and the defect is mobile. So cleaning up the edges here. Usually these actually hinge the opposite way, but his towards the PCL, but his went that way. And so you have to open the defect the way that it wants to go. You want to try to maintain whatever hinge you can. And you can see there's sort of this whitish appearance to some of the bone underneath. And what we're trying to do is we're trying to debride that. I think about these OCD lesions as these are essentially non-unions. And so we're trying to do, just like any fracture fixation, you prepare both sides of the fracture, you clean up the area of the fibrous or non-healing tissue. And so we're just cleaning the stuff up to try to get a healthy healing bed to heal. And after cleaning some of it up, I even do a very light, gentle on the defect itself. This is probably not necessary, but I do a little bit there just to kind of, again, address both sides of the fracture. And then what we're going to do is I'm going to drill holes into the defect bed with a wire, again, to better access the deeper elements, and then reduce the fragment back once I feel like it's prepared. And then we're going to pin it in place. So I'm using a switching stick here on the left to hold it as I get my first wire in. And then eventually I've placed 3 wires. This is already after 1 screw is already in place. I'm drilling for the second one, just drilling through into the base a small amount. And then we're going to place a screw, again, stabilizing it while it's going in. And then here we're going to place our last screw. In this case, it was 3 screws that went in. Okay, so after I place these metal screws, they're limited in their weight bearing until their subsequent visit for hardware removal. But you can see here, this defect was well stable after fixation. And so, usually we do heel touch weight bearing or down weight bearing for several weeks. And then I went back around 10 weeks postoperatively. This is our second look arthroscopy at 10 weeks. So you can still see 1 suture there on the meniscus, and then underneath you can barely see the edge of 1 other suture. The rest of it had healed, and the sutures had sort of synovialized. You can't see them at all. So this is great. So we were able to save his meniscus, or at least the part that we repaired, which will benefit him. And then just cleaning up the edge there. And then if you look at his OCD lesion, you can see that along the edges there, it's healed in. And so sometimes it's harder to find the location of your screws, even though you only bear them a millimeter or so. But the lesion was stable. There's some fibers from the PCL there around it, but it's not moving at all. Oops. And whoops, we'll get back here. And so we're going to remove these screws one by one. And usually when we do remove them, we cannulate them. So I'll just show that real quick before. Another thing to know is that, when you do these the first time, it's very helpful to write down, especially if you're doing this with a scope, to write down the angle or the degree of knee flexion at which you place them and which portal or percutaneous incision you place them through. That way it's easier to find and get the right trajectory. But this is him. This is after screw removal, looking at the defect. And again, it's even after we take the screws out, it feels solid. And thankfully, this patient has returned to impact activities in running and triathlon. This is another patient I just had follow-up with speech really quickly, an OCD lesion. She's a 14-year-old competitive basketball player. This large lateral condyle OCD lesion. You can see here, for her, when we talk about the ratio, this lesion itself took up like the majority of her condyle. So we did a similar technique, fixed it with screws, and then at 1 year post-op, this past week she had an injury, new injury, and we got an MRI just to ensure everything was okay, and you can see the defect bed has healed, which is really cool to see compared to the prior MRI. When we look at Macy, so this is a patient who I treated who had a trochlear lesion. You can see the unstable edges here. And so again, we'll do a chondroplasty, find the edges of the defect, clean them up until we get to a stable beveled rim. I'm just measuring the defect, getting an idea here. And then this is me taking the Mason biopsy. So we're going to take a ring curette. I like to do this from the intercondylar notch. I find it helpful to go from inferior to superior and sort of walk the curette up to get the sample. And then we'll take that and send that to the lab. This is when he subsequently remained symptomatic. We went in for MACI implantation. I think this was about 8 months later, and we're preparing the defect. This involves the area that we clearly defined earlier, plus a little bit of cracked cartilage around it. Try to create vertical walls. This is the MACI implant. It's critical when you do that, when you do this, to orient the implant the right way, because there's a certain side where the cell side is up or down, and you need to be oriented the right way for this to work. And so I always make sure 100 times and make sure with everybody else in the room that we have this oriented the right way to be able to implant it. And then there it is, implanted into the patient's body. And the last case I have here is for an osteochondral allograft. This is a patient, also mid-30s male, who had prior meniscus surgery, partial meniscectomy. It seemed to be a small area, but he was symptomatic and he couldn't work. He had pain with walking, in addition to inability to do daily activities. And so we started off with chondroplasty. You see here, this is after chondroplasty. This is what the edges of his defect look like. Again, he was subsequently symptomatic. This is the medial pharmacondyle we're looking at. And so here we're going to do an osteochondral allograft transplant. So I start off the case. I'm just going to review statutory address and bone marrow aspirate, which was concentrated in the back field. We identified the defect through a medial peripatellar arthrotomy. And then what I'm doing here is trying to find the center of the defect. And key is with these to stay perpendicular as much as possible. And again, this applies to any cartilage surgery. You want to stay as perpendicular to the defect as possible. I have a pin. I'm going to now ream to a certain depth. So usually I set this to around 7 to 8 to try to get 4 to 6 millimeters of subchondral bone that I've reamed. And then I'm just going to gently dilate the area. And now I'm taking measurements on all the different corners of the all the different 3, 6, 9, 12 o'clock of the defect to try to best understand how it's shaped. I saved the extra readings in case I need extra bone. That's what's shown there. Now here we are in the back table. This is our allograft. I've placed it into a large basin and I'm submerging it underwater to help reduce thermal energy. And then we're going to ream for our plug here on the osteochondral allograft. And then I flip it over and I even saw the correct depth, again, underwater to limit thermal damage. You can sort of see this gassy stuff in debris, which is very common. And before I remove the plug, make sure you have it oriented and gently free the plug from the rest of it. So here's what the plug looks like after it's taken out. We're using the same measurements in multiple locations along the clock face to make sure that we can get this to match in terms of the bone depth all the way around. And again, as much as possible, irrigating and trying to reduce thermal energy. And here we are just kind of fine-tuning the edges, beveling the edges to make sure that it can fit very well without requiring much impaction. And then double checking, this is one of those things you always want to double check, triple check. Again, the same principle applies for autografts, osteochondral autografts as well. And here we're creating small little grooves in the bone to again decrease the impaction force necessary. Then we're going to take this through a pulse lavage, again, to remove and reduce immunogenic elements as much as possible. After it's pulsed, we're going to use this pressurized carbon dioxide, and that helps increase the porosity and improve, again, access to deeper elements of the graft. And I know it's hard to tell me, but there's way more pores you can visibly see after using the pressurized carbon dioxide. And this is bone marrow aspirate that's been concentrated and injecting into the graft. And once you've done this pulse lavage and pressurized carbon dioxide, you can see how the bone marrow aspirate just soaks itself into the graft without even using that much. I'm not barely putting any in here, and the whole graft is being consumed by it as opposed to falling off the edge, which is a really nice technique. And then when we're going to put it in, I put a suture behind the graft. So here's me trying to put this graft in, and I sort of messed up and it's tilted. And so I want to be able to pull it out safely. And so this suture actually works very well for that. Having an assistant keep a hand near the graft so don't lose it, and you just gently pull it off and it pops off very easily. So it's a nice technique to save yourself. And then here I am hand pressing it in. I really try to not impact the graft, and I'm getting pretty close here. And I'll do is I'll put a wet lap on top. And if I absolutely need to, I will use the impactor without a mallet and just use that to push. Again, sort of just like my finger, but just a little bit more rigid to help get the edges of the graft down. And here I am just looking, making sure that's flush. The cartilage surface looks good. And then we will get ready to cut the suture out from behind it and remove the suture as such. And then after I'm done, I always sort of pulse again with pulse lavage, and then range the knee after that to make sure that everything looks stable, and that we have a nice press fit of the graft. So here we are ranging the knee. And then, overall, pretty happy with this result. This patient is now, I think, about a year and a half out, doing quite well. So all his symptoms are completely resolved. So it's a great procedure for long-term durability and impact. And so after showing a few cases, I'm going to go back to a summary of the key components of sort of how you should approach these. Again, chondroplasty and debridement is my first line treatment. And this is for patients who are having mechanical symptoms, someone who's in season, and especially for staging for subsequent procedures. So this is, as you can see here, there's lots of loose cartilage here, that this is certainly causing pain. And so chondroplasty and debridement for this can help the patient do quite well, and they did after this. Then we go into microfracture and marrow stimulation. My personal practice, it's not as much, but that's also because I have resources for other options. I really use this for mostly small lesions in less remote areas. And if you're going to do it, drilling is certainly preferred over the actual awl, just to get deeper access. And if you have the available resources doing what we call microfracture plus, where you add micronized extracellular matrix or autologous cartilage, can be beneficial. And again, this is an elbow that I'm showing here. Osteochondral autografts or OATs, really good for high activity demand athletes, again with symptomatic lesions, ideally less than 1.2 centimeters squared, although those can be hard to find in the femoral condyle. Again, if they're bigger, you can do more plugs and do more of a mosaic-plasty thing. But I like these for femoral condyle small lesions. And then MACI, really good for young patients, multifocal lesions, oddly shaped lesions. MACI can be helpful in the patellofemoral joint where contour matches for OCAs are more challenging, although an OCA still performs extremely well in the patellofemoral joint, and those with minimal bone involvement. And then for me, an osteochondral allograft is my primary go-to for large and deep lesions, especially those in the condyle or in lower load-bearing areas. Those with bone involvement, if you have bipolar lesions, if there's any meniscal or concomitant HTOs, I typically like using an osteochondral allograft, and certainly for revisions of prior cartilage surgery. And then, just not to forget about these single-stage solutions, although these are not frequent in my practice to have to use, these options are very good for regions of the world where fresh allografts or cell-based therapies like MACI may not be available. They are more cost-effective than using an osteochondral allograft, require less resources. In general, most of these are better for smaller lesions than larger lesions, and do better with unipolar lesions. And a lot of these need longer-term studies, but I think the one that I'm most interested in, and might be better for larger lesions, and I think one of the reasons why I'm hopeful it works very, very well in long-term follow-up, are these aragonite-based scaffolds, because they, unlike the ones above, it also are addressing the subchondral bone. And I think that's where this one may stand out, but we'll have to see with longer term studies. And if you're in a lesion in an area where you do not have any allograft options, even some of these off-the-shelf ones, for smaller lesions, just don't forget chondroplasty and debridement is a treatment, and patients can do quite well. And even if they do well for a couple of years and then deteriorate, you still bought them a few more years, as opposed to doing a procedure right away that may deteriorate faster. If you do microfracture, especially for a moderate-sized lesion, just remember to have an honest discussion with the patient that outcomes do deteriorate over time. And then after that, you may not have as many options available. So still chondroplastic debridement is still my first go-to. But other things to consider is using autologous mixed cartilage, or if the lesion can accommodate and it's not too much donor site morbidity, osteochondral autograft transfers. If you have a larger lesion, again, initial chondroplasty, if you have access to cell-based therapies, then it can be helpful. But if it's a deeper lesion, there have been some who discuss doing bone grafting and subsequent ACI, or even something called the sandwich technique, where you bone graft and do some MACI. And if you have access to it, to enough plugs, and the patient's okay with it, then, a mosaic-plasty can be beneficial. And then don't forget that, in some cases it's not appropriate, or we cannot always save cartilage. And sometimes arthroplasty or unicompartmental arthroplasty can be appropriate. And if you don't have access to allograft or cell-based resources in general, just always remember, we have our basic toolbox that all of us orthopedic surgeons have access to. We all can perform arthroscopy and debridement. We can do microfracture drilling. Osteochondral autograft transfers can be helpful because you have local tissue. And, ultimately we have to remember, like, mechanics always, should come along with the biology. And in some cases, mechanics are more important than biology. And so thinking about the alignment, meniscus, ligament stability, and the power of an osteotomy is really quite tremendous, and can sometimes just be enough on its own. And I think that the most important things about cartilage surgery is that the decision making is often harder than the procedure itself. Technically, I'm quite sure most surgeons can do these procedures. The hardest thing is the decision making, the discussions with the patient, and knowing that no solution is perfect. We're always learning cartilage surgery. That's why I love this field. It's sort of my area of interest and passion. And there's things to learn from both successes and failures. But ultimately, if you remember the basic principles, we want to treat symptomatic defects. Skillful neglect is a valid option. And ultimately, although some of these bigger procedures are a lot of fun and look really cool in images, we want to do the least that you need to do for a successful outcome. And chondroplasty and debridement can do quite well. And so really a lot of this is counseling patients, managing expectations. We do have good return to sports rates after these procedures, but there are also high reoperation rates that need to be considered. And ultimately, with more and more experience and more technologies, I think we're going to get to a place where this decision making is not as hard. And with more and more experience and learning from high volume surgeons and big cartilage restoration centers, will hopefully get a great cartilage preservation practice worldwide. So thanks for your time. I appreciate the opportunity to talk today on articular cartilage injuries, and happy to talk about any questions.
Thank you, Sachin. Sachin, you can stop sharing.
Okay.
Thank you, Sachin, for this spectacular presentation. Great cases, surgical technique. And man, congratulations for the amazing work that you do.
Thank you. No, it's I'm lucky to have a fairly high volume cartilage practice, even a few years into practice. So.
And you have great mentors as well, right?
Oh yeah, I mean, I wouldn't be able to do any of this without them, or feel comfortable approaching these procedures. And I think that's something I'm very fortunate about and feel very lucky about. And hopefully, giving talks like this can also help share the wisdom I've learned from them with others around the world. So,
Sachin, I just want to know your perspective about ACI, cartilage, in my autologous cartilage implantation, because do you think that could be the gold standard, given the fact that it is not allogenic? There's no donor site morbidity, and you're actually regenerating the patient's own cells, right? The reason I'm asking you is I have a few surgeons in the UK, I've hosted them, and I found them that they find it difficult with respect to the logistics. What they do is, in the first part, they harvest and send it to Germany, and the culture is done in Germany and by a company, and it's being sent back to the UK, and they have to schedule the case, because once you send it, you have to implant it within a few respective days. So what's your take on ACI in the US? And do you feel that the other forms are better?
no, I mean, I think so. Like ACI or MACI, I think the benefit is it's the patient's own cells are being grown, right? The big downside, as you allude to, is just sort of the resource to have it, be sent. I mean, in the U.S. it stays locally in the U.S., but in other countries, it's true, it goes elsewhere. It's a little bit more logistical challenging. One benefit in the U.S. is they store the cells for 5 years. Here, at least, I'm not sure if that's worldwide or not. And so, that gives us time for the patient to declare themselves. If the initial debridement chondroplasty did well, then you have 5 years to decide. You don't have to rush to go do something, which is nice. I do think it's a powerful procedure. I use it a lot in the patellofemoral joint. The challenge with it, I think, is still that it doesn't address the bone underneath, right? And so it's great for a surface-based procedure. But if you think about a lot of the defects that we do see are involving the subchondral bone, and that's where it becomes a little bit more challenging to say, that's the universal procedure. And so, and that's where in my practice, osteochondral allografts really are the go-to.
And in Sachin, and few of your cases, you've used titanium screws, right? Do you think a bio screws would have been better because you don't need to go again and take it out?
Yeah, so no, and bio screws are a super valid option, and they can be great. One of the reasons I don't like bio screws is there is a chance of a reaction to them, a synovitis or cyst formation, and when you get those, then the cartilage fixation is far more likely to fail. The nice thing with the metal screws I like is you get really good compression. Cost affordability is there certainly. But the second look is both a good thing and a bad thing. And it's also not good that the patient has to go another surgery to get them out. But if you go in there and you can see that I feel that the defect is healed, I feel much more confident progressing their activities. When you look at it. And if it's not healed, well, then at that time you can remove it. You're already in there and plan for the subsequent surgery, osteochondral allograft, or whatever it may be. So I still prefer the metal screws personally, but bio screws are wonderful. They work most of the time phenomenally, and you can avoid the second surgery, which is a big deal.
And what is the trend with respect to these company-based, for example, Mince cartilage, AutoCart by Smith & Nephew, and aragonite-based products, because you can buy them from the company and use it. No, I mean, there's not much of work to be done, so people can procure it and they just go ahead with the surgery. What is the trend in the US? Are more and more people doing this? Because Mince cartilage, I'm concerned because you're damaging the entire architecture, right? You're just mixing it up and just putting it back. So does it make any sense compared to, I mean, just microfracture alone, which gives you fiber cartilage?
Yeah, I mean, I think the idea behind the Mince cartilage, at least you get some sort of cells, native cells nearby. But yes, yeah, I mean, it's not ideal. And I think, most higher volume cartilage surgeons in the US are not really jumping to these techniques. And part of the reason is we don't necessarily have to. I mean, people who are doing a lot of cartilage surgery have the resources to do MACI or an OCA if necessary for larger defects. So that's why, my personal algorithm, I don't really do those procedures. Now, do I see some benefit? Yeah, I mean, it can be beneficial, especially for smaller lesions. Or if you're not comfortable with doing another cartilage procedure, you want to try something to get someone and see if it works. And all the studies in these are really short term, short, maybe midterm at best. And so that's what's challenging, is we don't really know what the durability is. I think I mentioned this earlier, the aragonite-based scaffold sort of piques my interest a little bit more because of those options that I did discuss. It's like really the one that addresses the subchondral bone. And it's trying to promote local chondrocyte migration and adhesion on the surface level of the implant, which might actually be a good option. I mean, we'll have to see, but it might be an even better option. And it's not an allograft either, and so it's beneficial.
Sachin, we are also joined by Loiy. Loiy, is he there? Loiy from Dubai. Loiy,
Hello.
welcome to the show. Any questions to
Thank
Sachin,
you.
please?
Thank you. Good morning, Sachin. Excellent talk. Really enjoyed it, and I think this is one of the most important talks nowadays. So it's so Sachin, maybe one question for you: if we have two surgeons, they do the same procedure for the same cartilage, like let's say cartilage repair, but we end up with two different outcomes. What do you think? What's the cause of this? Is it the technique? Is this patient selection? What do you think the cause of this?
Yeah, so that's a great question, and I think part of the answer is we don't always know, right? So I think same surgeon or two different surgeons, same surgery. Let's assume the patients are the same too, because some patients the same defect may also be associated with an alignment issue, right? So if they have an alignment issue, I'd say, well, the other one with the alignment issue is more likely to fail. I do think surgical technique is a big deal, but Again, I actually think patient selection is the most important thing. The decision making and the expectations, and you have to understand, like, why are we saying the patient did not do well? Are they doing well because their expectations were not met, or are they not doing well because they're, objectively their whose scores or whatever are low? So a lot of this is managing expectations ahead of time. I tell all the patients beforehand, there's a high rate of you needing another surgery in the future. That does not necessarily mean it's going to be a big, giant surgery again, but small surgeries are very common, to go back and do debridements. And so really setting the patient up, these are my longest conversations in the office. It's, you spend a long time with these patients trying to explain to them, like, why I might need to do 2 surgeries or multiple surgeries, what we're trying to achieve here, where the current state of technology is. I think, especially in orthopedics, we're so used to seeing things like a fracture, you fix it, and most of the time, I mean, of course, there's non-unions, malunions, but, like, most of the time, most fractures we treat heal and patients get back to, whatever basic function. In cartilage, it's not the same. Just because you think you fix the problem may not mean that you fix the problem, or you've not resolved the problem to what the patient's expectations are. And so I think that's a
Yeah, Churchill, I agree. Excellent point. So in one of the slides, you say that don't treat asymptomatic lesions. So how would you differentiate between incidental findings and symptomatic lesions?
Yeah. So an example of this is just someone I saw last week. Okay, they came in. They have a medial meniscus tear. Their pain is all medial, and their MRI is on the lateral side. They have a lateral osteochondral defect, and the patient was not worried about the meniscus tear. Actually, they had a friend who had a meniscus tear, and they came to me because they have this cartilage defect, and they didn't want surgery for the meniscus. On the opposite side, they said, I don't want surgery, I'm going to do a PRP injection. That was their game plan. But they're like, what do I do with this cartilage lesion? And I'm examining him, I'm pushing the lateral side, he has no pain. I said, where's your pain? Never on the lateral side. So for him, I said, look, this is there. If it starts bothering you, let me know. Now you know to be aware of it, but there's nothing that we need to do about it. And if you're, whatever you want to treat for your meniscus on that side, then that's fine. So sometimes we'll find things, especially it's common in the patellofemoral joint. You find little cartilage defects, a little bit of chondrolacia, things like that. They don't always need treatment. The analogy I might give is a rotator cuff tear. We see a lot of patients with rotator cuff tears, or slap tears, probably even a better example. They have a slap tear on their MRI. We know slap tears are extremely common after a certain age, and we don't go in there and do a slap repair or biceps tenodesis on every slap tear that we see. And because it may be a part of their normal aging, or it's just not symptomatic. So we treat symptomatic slap tears, of course, but so I think trying to understand, really, like, where is their pain when you push on that side, are they really experiencing symptoms, and are the symptoms that they're experiencing typical for an osteochondral defect? For example, is it a loading issue versus I'm sitting here and not, I rest, or every time I stand straight for an hour, it just kind of feels sore. Probably less common than someone who's experiencing pain with more walking, more impact, more loading.
That's true. This is my take-home message here. Just sit with the patient, talk to him, examine the knee, examine it, understand what's going on, rather than just, this is the cartilage here, we need to do with cartilage, and maybe the issue is not with the cartilage, something different, or vice versa. That's definitely, this is really important to understand. That's why I asked this question. Maybe my last question won't take a lot of your time. Is if we consider that microfracture will lead to fibrocartilage, and fibrocartilage is inferior to the hyaline cartilage, why we are still doing it? Is there something that, are we burning the bridges, or is it really something we need to stop doing it?
Yes, it's a great question. Honestly, I generally feel like the indications for microfracture are getting slimmer and slimmer. I mean, part of the reason it's done so much is, when the challenges with cartilage surgery is not many people are trained in it, right? And so microfracture is a very simple procedure. Everyone knows how to do it. Everyone has the tools and resources to do it. And you see something and you feel like we need to do something, right? So like we see something like, oh, we should do something about it. And so that's why I think it's being done a lot. And but no, I mean, truthfully, I don't feel that microfracture really has that many roles anymore. And I think the challenge also with a lot of the studies on the single stage off the shelf solutions, they're all comparing to microfracture. Microfracture is a historic treatment, and really more and more studies need to compare more modern treatments as opposed to comparing to a microfracture control group. But I think it's just happening because people don't have as much exposure to these other treatments or training in them, and it's just what we're used to historically. But I don't think it's really an option.
In my practice, I stopped doing microfracture. If I'm doing just micro drilling or small, tiny micro drilling, just not to burn the bridges. Maybe the last question. If we can predict the healing potential of doing meniscus repair. Do you think we are able to predict the healing potential of doing cartilage transplantation?
Yeah, I mean, I think we're getting close, but it's hard to know like the exact, healing rates and healing potential. Sometimes, even in a procedure that's extremely well done, extremely well indicated, all the other factors that are addressed, alignment, BMI, meniscus, people still don't always heal, right? And so I think, one of the main things that we're looking at more and more is why are they failing? Can we identify factors for failing? So would I say, can we predict the healing potential? No, not necessarily, because sometimes even the best indicated and best done procedures will still fail, and we don't understand why. But we're getting closer to that, and hopefully that's something that we'll be able to predict more readily.
Yeah, that's a great point, because if I'm not sure how you do you analyze your failures? So is that this is what, if you analyze your failure, let's say what parameters you use or patient-related outcomes you rely on to analyze your failure. Might be patient selection, is my technique related, or biology. So I think this is a great point to add. Sachin, thanks a lot. Great talk again, and looking to meet you again.
Yeah, thank you very much.
Thank you, Sachin.
Thank you.
I think that's all the questions that we have for this session. Thank you for this wonderful talk, and really look for more in future.
Yeah, thank you so much again for having me. I'm really looking forward to having this on the channel, and lucky to be a part of the awesome educational structure you've built. Thank you.
Thank you. Bye-bye.